examination that we do in the upper limb. And then when the patient sit up, you can also ask the patient, because for examination of lower limb, it's either you ask the patient to lie down first and examine for heel shin test, or you can, if your patient is in a sitting position, you can ask them to get up first, okay? So they can stand up, okay? Ask the patient to stand up, and then you examine for any wide-based stance, okay? So first, don't ask the patient to walk yet. You ask the patient to stand up, and then you look at how they stand, whether they stand in a wide-based stance, okay? And then you see if there's any swaying to any side, okay? Then after that, you ask them to walk normally first and see how they walk. If they can walk normally, then we do a tandem gait, okay? If they cannot even walk normally, they have very imbalance, usually you don't need to do a tandem gait anymore because you already got the ataxia, okay? And then another thing, if they can stand still without falling, you can ask the patient to do a Romberg test. Okay, so Romberg test is not a cerebellar sign, but Romberg test is only done if the patient has a ataxia to exclude ataxia due to posture column disease. Okay, so and then you can also, while the patient is still sitting earlier, you can also check for the pendular leisure, which is part of a cerebellar examination. Okay, so these are the important examinations that you have to show to your examiner, and it has to be complete and thorough and with a correct examination. So we will start with the inspection. Okay, can you do the inspection? So you have to introduce yourself. Okay, put the patient comfortably in a comfortable position. And you can, usually we start with the sitting, which is cerebellar, you ask the patient to sit up. So sitting, and then you have to be in front of the patient. I think maybe you, right. Okay, so you start with inspection. So inspection, you have to mention if there is any incubation or so. You nak lakon, ada cerebellar sign, lakon. Just lakon cerebellar sign. Okay, so you have to observe for that. Okay, and then we go to the examination of the eye. Okay.
Selamat pagi Puan, nama saya Chai, pelajar perubatan tahun 5. Hari ini kami akan cek seluruh badan untuk tanda-tanda ada saraf.
You don't need to explain too long, okay? So usually we say our name and we say that we would like to examine which part of the body, maybe the face and the limbs and so on. Okay? So ask patient whether you can do it or not. That's all. No? So don't talk too long. Just briefly, directly say to them what you are going to do. Okay?
Kami nak periksa bahagian kepala, tangan dan kaki sikit lah. Boleh ke Puan? Boleh. Ada sakit mana-mana tak sekarang? Tak ada lah. Okay. First.
Okay, cuci tangan dulu. Okay, then.
On inspection, there is hip intubation of the patient. Should I do running commentary or at the end of the
Usually in exam, you have about 7 to 8 minutes to complete the examination. Okay, and then you present for 2 minutes, and after that 5 minutes for discussion. No? So you should practice. Try to do your examination in 7 to 8 minutes. If you extend only up to 9 to 10 minutes, but don't go beyond that because you will not have time for discussion. Okay, so I quickly examine the eye for the nystagmus. So we usually nystagmus you have to put a slow movement. Okay. You can use your finger or you can use anything that can help the patient to follow. Okay, so
dapat satu ke dua? Satu.
So slowly, don't go too fast. So first, when you observe the eye, you just see at least spontaneous nystagmus at rest, at rest before you moving the thing, and then you just move to the side. Okay.
Jangan gerak kepala, mata
stimulus up inversion, you tekan inversion. Okay. Okay, so finish with these timers, then we go to the speech. Okay, so speech in cerebellar, the most important is to ensure that patients speak fast. Speak fast. So because if you want to listen for scanning, you have to give a sentence so that they can speak fast. Okay, so.
Puan, boleh sebut Persatuan Petani Pulau Pinang?
Persatuan Petani Pulau Pinang.
Okay, so scanning speech is like that. They say it slowly, one word by word. That's why you have to ask sebut cepat. Persatuan Petani Pulau Pinang, so sebut cepat. So normal people they can say it fast. Okay. But for the cerebellar patient, they will start to do like scanning a bit slow. Okay. And then after that, you go to the upper limb. So first you check for tone. Again, check for tone of the limbs. The tone is a normal like we do. Check for tone. Okay. Then after tone, you go to you can do a rebound hypotonia first. So there are two ways you can do like that. You can do like that and you press down. So you have to tell the patient. They have to tell the patient. They have to hold there. Okay. Try to resist you. Okay.
Lawan tangan.
Tahan.
Tahan.
You just put your hand on the forearm, not at the wrist. Okay.
Oh, okay.
Lawan.
Lawan.
That. Okay. And then the other side. Also.
Oh, do one.
Do one at one time. Okay. Or you can do another way is to do like this. So this one you have to cover the patient's face. Okay. So you ask the patient to you have to hold at the forearm. You have to hold at the forearm. Okay. And always make sure you cover the patient's face, because if the patient has rebound hypotonia, they will start to they won't be able to hold that. They will hit their face. So always cover the patient's face. Okay. Then we go to the finger nose test. So finger nose test is important to do it fast, and always tell the patient to always touch with their the palm of the fingers. Okay. So they have to change their position. Like always use the palm of fingers, touch the nose, and touch the head finger. The examiner finger also with the palm, so that they switch. We don't want the patient to do like this, which is on the side of the fingers. Okay.
Puan, sekarang saya nak Puan guna jari, hujung jari Puan, dan setiap kali saya gerak jari, Puan ikut je sentuh dekat, betul-betul dekat hujung jari saya. Boleh ya? Cepat. Sentuh hidung Puan dan sentuh jari saya.
And then the hand of the patient should be straight. You should put an adequate distance so that the patient touch your hand to straighten the elbow. But not too far away, because too far you cannot reach. But just ensure the elbow is straightened.
Ya, boleh tukar tangan sebelah tu?
Okay, so for dysmetria. Okay, so dysmetria plus OT. And after that we do the dysdiaphanesia. Okay, dysdiaphanesia also they have to always switch the movement. Okay, because we want the muscle to coordinate, so we want the muscle to first like this and then like this. So always switch, not just like this. Like this means that if you don't switch any muscle activity. Okay, so we always make sure you should touch like this and then after that switch the movement.
Sekarang Puan, saya nak Puan tukar tapak tangan cepat-cepat dan angkat tinggi-tinggi ya. Cuba tangan kanan dulu dan buat cepat-cepat, secepat mungkin. Okey, cuba tangan kiri.
Balik terus. So these are the dysdiaphanesia. So two examinations. So these are the three examinations we do in the upper limb. Okay. And then after that we go to the lower limb. So lower limb, while sitting, you can do if the patient is lying down, you can do a heel shift test, okay? So you can either do while sitting, and probably kalau you want to do heel shift test later also can. So it depends. So the patient, because usually the examination, we want the examination to be smooth. No? We don't want the patient to lie down, get up, lie down, get up, like that. So while you're already sitting, you just do a pendular linger. Pendular linger, usually you have to stand next to the person. Okay? And then you just stand up, you don't need to sit down, and then just sit from there. Just do like that, okay? So the normal linger will be like 1 and 2. So if it's like above 3, it's called a pendular linger. So you have to do both sides. So you should stand on the side, and then you just hit like you did earlier. Okay, so and then when the patient is still sitting, you ask the patient to stand up. Okay, stand up. So you see how they stand up. You look at their feet, whether they are having a broad base, whether they are tend to fall. Okay, so you must always stand next to the patient because the patient may fall down. Always when you ask the patient to stand up, you always be at the patient's side in case the patient falls down. Okay. And then if they're okay, you can do a romper test at the same time. Okay, so rapat kaki. Romper test is just put the feet together and close your eyes. Okay, and okay, so romper test, when the moment they close their eyes, they are falling down. And then you ask the patient to walk normally first. Okay, jalan biasa. So they can walk. So if they can walk normally without falling, you do a tandem walk. Okay, so do a tandem walk. Tandem walk, you show the patient how to do. And always walk with the patient in case they are falling down. Okay, so after you do that, you ask the patient to get on the bed again and do a heel shift test. Okay, so you have to ensure your examination are smooth. That's why even though you can do earlier, it depends on how you examine the patient in the first place. Okay, kalau you examine the patient tu memang baring on the bed, you can do a heel shift test earlier, and later you ask the patient to stand up indeed. Okay, tapi kalau you ask the patient to sit on the chair, then you can do it like that, and then later you do a heel shift test.
Boleh angkat kaki tinggi-tinggi dan letak dekat lutut dan gosok sampai tapak kaki dan angkat balik dan letak balik dekat lutut dan buat cepat-cepat.
Okay, so you have to put your hand there so that they don't lift up too high. Okay, you letak kat kaki tu, kat bawah tu, dekat sebelah atas sikit, atas dia. Okay, atas sikit lagi kaki. Okay, you ask the patient, start from the lutut. You have to give a clear instruction. Start from lutut, turun bawah, sentuh tangan. Start lutut, sentuh tangan, and pergi ke lutut, turun bawah, dan sentuh tangan. Okay, so and then do the other side.
Kaki sebelah lagi.
Okay, daripada lutut, turun bawah, and then sentuh tangan. Sentuh tangan itu jangan rendah sangat, nanti dia tak boleh nak lalu. Okay. Okay, so these are the things that we do. So these are the cerebellar examination. So any question about cerebellar examination?
Regarding the walking distance, like how far should I ask the patient?
You just walk from here to like a bit from here. Antara situ je, sebelum tangga, sebelum yang sikit tu je. But you always have to follow the patient. Don't allow the patient to go without. And always look how they walk when they do the test. While you following them, you look at their feet. Okay, so these are the cerebellar. So you have to practice and make sure you can do it within several minutes.
So, we need an examination first, and then for the finding, you see the relevant causes for the finding.
Yeah, so after you finish your examination, you have to present. So presentation is always in the order of how you examine. Okay, so you start with inspection. When you present, start with inspection. You see a head intubation, and then there is no nystagmus, the speech is normal. Okay, in the upper limb examination, there is no listed dystonia, or there is dysmetria or intention tremor on the right side. Okay, something like that. Then followed by lower limb. In lower limb examination, there is abnormal heel shift test on the right side, okay, or and the gait is ataxic, the patient is unable to do a tandem aid. So you have to present according to the sequence. You can say the positive finding alone, or you can just present the whole thing depending on what is the finding. Okay? And after you finish, you have to offer a differential diagnosis. So for cerebellar disease, you have to know what are the diseases that can affect the cerebellar. So what are the diseases? So anything that can affect the brain can affect the cerebellar. Okay, the common one that vascular stroke can be infarct or it can be hemorrhage. Okay, any other thing that can affect the brain? Other than stroke? Apa lagi disease that boleh affect the brain other than stroke? Mass, okay, tumor, also tumor in the brain. Lagi? Multiple sclerosis, okay, demyelinating disease, lagi? Vestibular arthritis is not a cerebellar disease. Apa cerebellar disease? Cerebellar, disease that can affect the brain or cerebellar. Selain daripada stroke, tumor, demyelinating disease, infection such as abscess or encephalitis. So all these are part of the cerebellar causes of cerebellar, or drugs. So which drug cause cerebellar or cerebellar sign? Parkinson, anti-epileptic drug. Okay, so you have to give at least 3 to 5 differential diagnoses. Every time you finish, give 3 to 5 differential diagnoses. Okay, and it has to be quick when you give differential diagnosis, because all these are just checklists that you have to remember before your exam. Okay, not going to only think during the exam. So most of the brain disease has almost a similar causes. So you just list down what are the common causes and just tell one by one. So when you go by exam, you have to immediately tell. So this is my differential diagnosis is one is stroke, second is like tumor, third is abscess, fourth is like demyelinating disease, and fifth one could be a drug use. So presentation should be like that. It's not like you tunggu, okay, stroke, and then examiner tanya lagi, what else? So don't wait for examiner to say that, okay? So at least give 3 to 5 differential diagnosis immediately. And then you probably, if you have time, they will ask you about the investigation. So in the brain, what is the most important investigation that we do? We do either CT or MRI, depending on what case. So if you think it's stroke, usually we just do a CT brain first, and may need MRI if you want to see, certain disease. And then subsequent investigation will depend on your differential diagnosis. If you say the diagnosis is stroke, then what would be other investigation that we do? You have to look for the causes of stroke. So when we say stroke, then we have to send investigation to look for the causes of stroke, or we look for the features of vessel in the or causes. What are the causes of stroke? Causes
small
of
vessels.
stroke. Common causes or risk factor. Hypertension, hyperlipidemia. Apa lagi common causes? Diabetes. So what investigation are you going to do for that? Lipid profile, HbA1c, okay? And then you check for the cardiac cause, or cardiac molar. So you have to do ECG to look for atrial fibrillation, okay? Echo, okay, what you want to see the echo? Apa nak tengok dalam echo? Clot, okay, vegetation, clot, valvular heart disease, or any dilatation of the chamber, or poor ejection fraction. Okay? Any other investigation that we do? How do we look for the vessel in the stroke? We do a CTA or MRA or what lagi? Ultrasound therapy. So these are the basic investigation that we need to do in stroke. So it depends on what is your patient, what finding you see in the patient. Okay, so patient may be having stroke, maybe having tumor. So if tumor, you have to screen for primary tumor. So you have to do all the investigation. If it's an abscess, then you have to send for some screening of the infection. Depends on what causes it is. So you have to have your own checklist. You make your own checklist. Okay, if it's a stroke, what are investigation? If it's a tumor, what are the investigation? If it's a rheumatic disease, what are the investigation? Okay, if it's a abscess or infection, what are the investigation? So all this checklist has to be done earlier before the exam. Okay, it's not that you go to exam tu baru nak fikir kat situ. Usually we do earlier, and then the moment in the exam, you just remember back what you have. This down, and then you just tell the examiner. Okay. Okay. So next one is examination for myasthenia gravis. Actually, for myasthenia gravis for undergraduates, usually they are not asking you to examine myasthenia gravis. Usually, they will ask you to examine the cranial nerve, because for postgraduate, probably you just observe and proceed. But for undergraduate, usually there will be a clear instruction to examine the cranial nerves. So cranial nerve, you just start from the first cranial nerve to 12. First to 12 cranial nerve. And then in myasthenia gravis, what are the features that we want to look for? We want to look for the evidence of muscle weakness. Okay, so myasthenia gravis usually they have a selective group of muscle or some more prominent muscle that is weak. So usually they have the ocular muscle weakness. So if you observe the patient during inspection, you will notice probably ptosis. Okay, ptosis in myasthenia gravis usually is a partial ptosis, not the full complete ptosis. So you have to observe the eye and see whether the patient has any drooping of the eyelid. Okay. And then if you see ptosis, what are the other causes of ptosis other than myasthenia gravis? So you can divide ptosis into whether it is a myasthenia gravis problem with the neuromuscular junction or problem with the which nerve usually cause ptosis? Oculomotor, third nerve, because third nerve supply the which muscle? That elevate the eye. Levator palmar superioris. So if there is an impairment of the third nerve, there will be complete ptosis. And in third nerve, you will see features of third nerve palsy, like dilated pupil, and you'll see impaired eye muscle activity due to third nerve. So which eye muscle will we impact if there is a third nerve palsy? Impact of third nerve. Impact other than lateral rectus and superior oblique, other than eye abduction and intorsion, downward intorsion. So the others are all supplied by third nerve, so should be impact in ptosis, okay, in third nerve palsy. And you should look for the pupil size to see whether to differentiate whether is it a third nerve or is it a neuromuscular junction or muscle disease. Okay? Another cause of ptosis is the Porter syndrome. Porter syndrome, you will see a small pupil size. So small pupil size, you can see a one-sided small pupil, means that could be a Porter syndrome. Okay? So these are the initial examination that can help you to differentiate. So in myasthenia gravis, usually we just want to confirm whether it's myasthenia or not by checking for fatigability. So if you see a ptosis patient, you just check for, you ask the patient to look up for 20 seconds, and then you see the upper eyelid whether it's drooping down in that 20 seconds. Okay? So that is the fatigability of the eye muscle. Okay? And then depending on your finding, okay, we also test for the fatigability of the bulbar muscle, because they may have a bulbar muscle weakness. So when you examine the cranial during your examination of the 9-10 cranial, you can ask the patient to count to 30. Okay, so this count is not a rapid count. It's just a normal count with a louder voice. Okay, so for example, you ask the patient to count 1, 2, 3, 4, 5, 6, sampai 30. So you listen to the voice, whether it becomes slower, whether it becomes nasal, whether the patient the voice still can maintain the normal voice or change in the voice. Okay? But you shouldn't count fast, because rapid one is actually to test for the respiratory. Test the respiratory, not testing the bulbar. The test for bulbar is just a normal count but loud, so that you can hear the voice. Okay? And you test the upper limb for fatigability by doing or asking the patient to exercise for 20 times. Okay? And then you examine before and after the exercise. So you check the power before the exercise first, and you ask the patient to exercise the arm muscle, and then you recheck again after you complete the 20 exercise. Okay? And see the difference. So these are the 3 fatigability tests that we do for myasthenia gravis. Okay? Others are just a usual cranial examination. Just look for ptosis, look for eye movement. Okay? And then you have to add on with these 3 fatigability tests for myasthenia gravis. And myasthenia gravis, sometimes they already have they have done thymectomy. So always look at the neck and the upper chest region for thymectomy scar. Okay, so these are for myasthenia gravis. For Parkinson, who wants to become the patient and who wants to become the patient and the examiner Parkinson?
考我这个什么会，不然今天学，这教现在没有人会 volunteer 可以。要给我读我现在。真的有读给先这里读我写下。行吗 ？OK 吗？给我看东西还蛮。
Okay, while waiting, I answer this one for cranial 1. You need to test it nostril or both together. So usually test nostril one by one. Yeah? So cranial 5, we need to perform corner reflex in Georgia. Georgia you can do. Okay, Georgia you can do, but corner reflex usually you have to tell the examiner that part of our fifth examination, fifth cranial examination is a corner reflex. Because the patient may be used many times by other students, so it's not comfortable for the patient to check, every time the student comes. So you, for fifth cranial, after you have examined the power muscle and sensory, and then you do a Georgia, and you tell the examiner that you have to do the corner reflex part of the fifth nerve. Okay? Exposure for upper limb examination. So exposure, it depends. If the patient is male, they probably can remove the cloth. Okay? But for female, usually you expose up to the shoulder only. We can ask the patient to remove their shirts. So you just lift up the lift up to the shoulder area. Okay? But you have to ask the permission from the patient before you examine the upper limb. We have to do rebound test and Hoffman for upper limb. So rebound test for what? For cerebellar. Rebound hypertonia. In normal motor examination, usually you don't have to do, okay, unless you are asked to do a cerebellar examination, then you do the rebound. Hoffman test for upper limb, it depends on your finding, because Hoffman test is not the first examination that we do. So usually, if you see the patient has hyperreflexia and upper limb which indicates it could be in the spinal cord, then you do a Hoffman test, okay? But Hoffman test is not compulsory for all the upper limb examination. How to eliminate gravity? The test for power in lower limb. Masuk dia ada. How to eliminate gravity? The test power in lower limb.
Huh?
Huh?
It's on the bed. Yeah. Bed 2, right? Bed 2, right? One is just like contraction or somehow to keep. What does it mean?
Sometimes orang ni.
Belly move.
Apa maksud dia? So nak test Parkinson? Boleh? So for Parkinson, okay, so Parkinson is a movement disorders, okay, it's due to some problem with lack of dopamine, okay, in your brain, and then Parkinson disease, usually we want to look for the features of lack of dopamine, okay, so what are the features of Parkinson? Bradycardia is a major feature, okay? Rigidity is a major feature, and then tremor is a major feature, and another one is the postural instability. Okay, so when we examine Parkinson, we have to look for these Parkinsonism features. So examine from head to toe as well, like cerebellar, and then you look for these features during examination. Okay, and then Parkinsonism can be due to idiopathic Parkinson disease, or it can be due to secondary Parkinsonism due to a disease like stroke, okay, or drugs. And a certain metabolic disease like Wilson disease, okay. And Parkinsonism also can be due to degeneration of multiple areas in the brain. We call it as a Parkinson plus syndrome. So it may not, the Parkinsonism, idiopathic PD, the Parkinsonism is due to the degeneration in the substantia nigra or D. But in Parkinson plus syndrome, degeneration can be multiple. Can be in the pons, can be in cerebellum, can be in the other structures like in cerebral cortex and so on. So that's why we call it as a Parkinson plus syndrome. So when you examine the patient, if you see a feature of Parkinsonism, then you have to differentiate. Is this a idiopathic Parkinson disease, or is it a secondary Parkinsonism, or is it a Parkinson plus syndrome? So additional examination that we do during examination is just to look for that. Okay, so the most important is you need to demonstrate the Parkinsonism features first. So usually we start from head to toe, looking for bradykinesia, looking for rigidity, looking for tremor. Okay, so in the head, what do you do? When you inspect, what do you inspect first? You inspect the facial expression first. Okay, so you have to inspect the facial expression. So usually, what would be the how do you want to know the facial expression? So you do like mask like face, and you ask the patient to smile. Okay, so can you smile? So you see how they smile. If they smile, if normal people have like all the freeze and so on. Usually people with severe Parkinsonism, because the muscles are so bradykinetic, they cannot even smile. No? They don't have expression. Okay. And then when you observe, you look also for the apa lagi, the bradykinesia in the muscle in upper limb that you can in the face that you can observe. The eye muscle. Okay, so the eye muscle. So they have a slow blinking of eye muscles, or sometimes very severe not blink. So you have to look at the eye muscle for blinking. Okay, whether they blink or not. So these are the two things that we observe in Parkinson. And then you start with the examination of the face by checking the glabellar tap. Okay, how do you do glabellar tap? It's meant from the behind or from the side. Then you tap between the
Try to do. So if the patient wears spec, you have to remove the spec. Okay? So you tap 2 per second, no? So you have to see the
okay, so you tap 2 per second and then you see whether the eye blink or not. So in normal person, what happens? After a few times you tap, the eye will stop blinking. Okay, but in Parkinson, usually because they have abnormal this reflex, and they keep blinking despite you tapping for many times. No? And then you go to speech. Okay, after you do before that you can do eye examination just to see the eye movement whether it's fast or not. So we call it as a saccadic eye movement. So saccadic eye movement, you put your finger and pen in front of the patient. Put a finger and a pen. Another one is a pen. Use 2 hands, okay. Ask the patient to tell the patient that you are going to test the eye and look for either the pen or the finger, okay. You letak dulu tangan depan, dua tangan you, jari you and pen, okay. Okay, so ask the patient to look at the pen. Jangan tunjuk. Okay, because we're testing the eye muscle whether it can move fast or not. Tengok pen, tengok jari. Okay, one actually at the center, another one at the side. Satu letak eye. Okay, you can do on the other side as well. You move the hand like that. Then you see and you can also do vertical, okay, like you will see, like that. Tengok pen, tengok jari. Okay, tengok pen, tengok jari. You can do up and down and see. So this is to test whether the eye can move fast or not. So if they have a bradykinesia, they will not be able to perform the fast saccadic eye movement. They will be a very slow eye movement. So this is the testing the bradykinesia in the extraocular muscle or the eye function. And then we test for the speech. Okay, speech you can ask the patient to say their name, or you can also do ask the patient to say their address, and then or you can ask the patient how they are feeling today, okay? Just to see their speech. So what kind of speech do you usually have?
Monotonous.
Monotonous.
Hypophonic.
Very slow, soft voice. Sometimes they
Slurred
feel
speech.
articulate, because it's very difficult. If their articulation muscle all become very kinetic, it's very difficult for them to say something. Okay? And after that, we go to the upper limb. So in upper limb, we can divide into testing for bradykinesia, testing for rigidity, and testing for tremor. So usually we start with the testing the tone for rigidity. So the tone for rigidity, you test the elbow, okay, flexion extension, pronation, supination, and then the wrist movement. Okay, these are the 3 things that we do. So can you do? And then you do the wrist movement. Okay. Dah laju tu tak? Pecah. You have to move slowly. Okay. So these are the three that we use for tone. So in Parkinson, what kind of tone that they have? What is the meaning of rigidity? In Parkinson, they have usually they have either lat pipe or cogwheel rigidity. What is the difference between lat pipe and cogwheel? Apa beza dia? Cogwheel dan lat pipe. Lat pipe and cogwheel. I have cogwheel is what? Cogwheel is there is a superimposed tremor. Okay, that part is the rigidity that you felt throughout the movement. Huh? So you have to test for this and then feel for any cogwheel or lat pipe rigidity. Okay, and then in our belief, after you test for rigidity, we ask the patient to put all the hand on the lap. Okay, okay, and then you observe for what type of tremor they usually have?
Resting
Resting tremor. Okay, they can have a P-rolling or just a resting tremor in the abdomen. So you observe the resting tremor. Sometimes at rest they don't have resting tremor. How do you accentuate the resting tremor? You can ask them to do some simple, some mental tasks. Okay? For example, you ask the patient to subtract 100 minus 7. Huh? Okay?
Cik boleh ke 100 tolak 3 berapa?
So sometimes they become stressed. They start being stressed. So you just want to observe the training. So only subtract 107 like 1 or 2 times and see whether the tremor is coming out. Okay? And then you test for after the resting tremor, we test for the postural tremor. Postural tremor, you ask the patient to sit like this, straight. And then you see whether is there any tremor. Or you can also do like this. Okay. And then you see the tip of the finger whether there is a tremor or not. So this is for postural tremor. And then we also test for action tremor. Action tremor is same like your finger nose test that you do. So you just do a finger nose test for action tremor. So these are the 3 tremor tests that we do. After the tremor, you look for bradykinesia in the upper lip. So bradykinesia, there are a few tests that we do. What are the tests? We check for finger tapping. Okay. We check for hand movement and also rapid alternating movement. So finger tapping, you just tap the first and second finger fast. Okay, ask the patient to do fast, and we see whether they can do fast and big movement. In Parkinson's disease, they can do fast, and after that it becomes slower, and the ankle becomes smaller and smaller. This is what we would like to see in Parkinson. Okay, and then other than finger tap, we do a hand movement. Just open and close the hand and see whether they can do it fast or not. Okay, look up self. Okay, and then you do the rapid alternating movement. So rapid alternating movement is just like you open the door. Okay, when you open the door from the knob, you watch function. So after you do that. So by right they should be able to change their, like open, close, and then so do it fast. So this is the bradykinesia in the upper limb. Okay. After upper limb, we go to the lower limb. So lower limb also you should look for resting tremor. Okay, and you check the tone in the lower limb. Check the tone. You do a knee flexion extension just to check the tone whether it's rigid or not. Okay, observe for any tremor in the lower limb. Okay, and we also do the bradykinesia. Okay, bradykinesia is by asking the patient to do the tap on the floor. So lift up one by one, do one by one. Lift up the finger, lift up the feet, and tap on the floor first. Okay, and then you do on the other side. So these are the things that we do to look for features of bradykinesia, rigidity, and tremor, the upper limb and lower limb. And after that, you ask the patient to stand up. So you look at whether they can stand up or not. Most of the Parkinson is very severe. They have difficulty to initiate the movement. So they have difficulty to get up from sitting to standing. And they probably have to use their hand to support in order for them to get up. They may have few tries before they get able to stand up. So these are the things that you should observe when they try to stand up. If they have difficulty to stand up, after one or two try, you can help pull them to get up. But first allow them to just get up on their own first, okay? And then once they stand up, you would like to see their posture, okay? Whether they have what kind of posture usually they have?
Stoop posture.
Stoop posture. So you look at the body, whether they bend forward, okay? Whether they hit, sometimes they bend to one side or bend forward. And then you look at all this, and then you ask the patient to walk. You have to walk with the patient. You can always walk with the patient. And then you see how you walk. So usually they walk. They have difficulty to initiate the walk, but once they walk, they will walk in the very small steps, and then they have difficulty to lift up the foot. We call it as a shuffling. They just stand and okay, so you try to show us how the Parkinson is. So they have a problem where they tend to have no posture. They tend to fall forward. So you have to look at that. Small step, and then shuffling, and then tendency to fall forward. At the same time, when you walk, you need to ask people to put their hand on the side. Okay, look for any loss of arm swing when you walk. Okay, and you can also do pull test, but usually we not advise the undergraduate to do pull test. Pull test is just to pull from behind. You can stand behind. Usually pull test is at the wall. Near the wall. And then you have to stand up.
You ask patient to turn or not to see the movement. Turn.
When they walk, you ask patient to turn to see. So sometimes they start their tremor, usually they're walking. So when they walk, you ask patient to turn, see whether they turn full, for example, you call as a turn and walk. And then you have to turn. And then if you want to look for features of Parkinson class, okay, such as the supranuclear PSP, progressive supranuclear palsy, we usually test for vertical eye movement. Vertical eye movement. So after you look up and down, they have a difficulty to test to do the vertical eye movement in progressive supranuclear palsy. Okay, in other Parkinson class syndrome like multiple system atrophy, they may have a cerebellar sign. So when you perform the finger nose test, you have to see whether they may be having some abnormalities, okay? And in some also usually test the posturability, lying and standing in patients with PCLAS. So all these are some of features of Parkinson class that you should either do or you can mention at the end of the examination that you would like to look for Parkinson class features. So these are complete examination of Parkinson disease. Okay, so anything else?
To see the pattern of the spiral.
You can write. So sometimes we, at the end of the examination, you want to see the function of the patient. Okay, you can ask the patient to hold the glass, bring a small amount of fluid, okay, just to see whether they can perform it or not. Okay, or sometimes you ask the patient to write or sign, write something just to see their signature or whether their handwriting has become small or whether they have this, like tremor they can do or this spiral, and then you can also ask them to button their shirt, okay, see whether they can do. So these are is the end of examination where you want to look for the function, patient's function, how they function in their life. Okay? So it's not compulsory, you can do, but it's not compulsory, you can just do at the end of your examination. So this one is what? Sudden onset weakness, right side of the body, the stage, hypertension, stroke agent. So what is the diagnosis? Sudden onset usually is a vascular, okay? Most likely diagnosis is what? Stroke. And most patients have hypertension. So most likely diagnosis could be an ischemic stroke. Kalau hemorrhagic stroke, usually there will be a headache, okay, or features of increased ICP should be written there. If not, that could just be a ischemic stroke. Side elevation. If the finding is on the right side and side elevation is on the left hemisphere. Okay, so side elevation depending on where, from the cerebral cortex to the subcortical to the brainstem, so it can be anywhere. Okay. Clearly expected clinical signs. So what are the clinical signs? Ini soalan yang you buat sini tu yang ambil mana?
Spot sendiri.
LGBT, because the finding here are actually not compatible with each other. So if a stroke, you expect to see an upper motor neuron finding. If one side with an upper frontal, they may have a hypotonia initially, but later on they become hyper. Okay. The expected clinical sign, it depends on what you have shown there. It depends on various patients. So it's not fixed to any clinical sign, because it can be, if it's a brainstem, it will be a brainstem finding, differential finding. If it's a cerebral cortex, it will be cortical finding. So investigation for stroke, what do you do? You do a CT brain. Okay, CT brain, and then you either CT brain or MRI. But first one, you always do a CT, and then you have to check for all the things that I mentioned earlier, to look for the causes of stroke and look for the source of the emboli, and look at the vessels. So all these are the few investigations that we do, and then all modifiable risk factors. So what are the modifiable risk factors? Hypertension, diabetes, smoking, obesity, so you can just name any. Okay, any other? Okay, so please make sure that you read the common disease, okay, for example, stroke, seizure, epilepsy, cardiomyopathy, all these are the common diseases that you see in a ward or you see during your practice, and most likely these are the patients that here in the example, because they are very common and so many patients that you can because it could be a dysarthria. So that's why I said that this question is a mixture of few things. Okay, but once there is weakness, it means that it involves your cortical spinal tract. It could be a cerebellar. Other patients may get cerebellar plus weakness, but cerebellar plus cortical spinal tract, but it's rare to get both. Like this. Unless they have multiple vascular problem, for example, like or it's still they can get multiple area problem. But most of the time it's a single area.
You kiss with them up.
Okay, so any other questions? Okay, most important is for you to practice. Our short case you have to practice. Okay, for this one week, make sure you do a thorough examination smooth and practice until you can perform in 8 minutes. Okay.
What's the difference between shuffling gait and also fastinum gait?
Fastinum is the one that fast. Okay, shuffling is the dragging.
So if Parkinson is both or
Both. Sometimes they have that fast, agility and fast move. Sometimes they have the shuffling, which is dragging the feet. They cannot even elevate their feet from the floor. Okay? Okay, any other question? Full test. You pull from behind. So full test for posture instability. So it's called as full test. Okay? Any other questions? Okay, so I think good luck for everyone. Hopefully all of you pass in your exam. Okay, please practice because your clinical must always practice in order for you to perform well in the exam. The more you practice, the more your brain register it, and it's easier for you to do it in the exam. Okay? So I thank you for all your attention, and hopefully, we'll see you as a house officer. Alright?
See you when you do house office.
这没有听。我换了啊。